This is Jiming Sun. I'm the host for this AI4H Care webinar, and this is, I believe, number 18 of the series. And I'm super excited to introduce our speaker today, Dr. Emily Alsentzer, and she is assistant professor in biomedical data science and computer science at Stanford University. Her research focuses on machine learning and natural language processing to augment clinical decision making and broaden access to high quality healthcare. She focuses on integrating medical expertise into ML models to ensure responsible deployment of clinical workflow. And Dr. Alsentzer completed her postdoc fellowship at the Brigham Women's Hospital, where she worked to deploy ML models within Mass General Brigham Health Systems. She received her PhD at the MIT and Harvard Medical School, and also holds a computer science bachelor and biomedical informatics master from Stanford University. And she has been also a leader in ML for Healthcare community, serve as general chair for the Machine Learning for Health Symposium and founding organizer for this SAIL organization, and also the conference on health inference and learning CHILL conference. So without further ado, let's welcome Dr. Emily Alsentzer.
Thank you for the introduction, Jiming. It's great to be here with all of you. I'm excited to talk to you about some of our work towards knowledge-enhanced machine learning for healthcare. If you have any questions throughout the presentation, feel free to ask. Hopefully we can make this interactive, and I'll also pause as well for any questions. Data-driven decision support at the bedside has been a long-standing goal in the medical community. Can we develop tools to provide the right information at the right place at the right time? And if you're in this room, you already know that there are many exciting opportunities for developing these kind of algorithms that can leverage healthcare data to interpret medical images, identify patients for clinical trials, provide personalized treatment recommendations, just to name a few. And we as a community have seen increasing progress towards this goal. There's been an over 5-fold increase in FDA approvals in machine learning devices in healthcare since 2017. This is great news. However, if we actually break down those FDA approvals by clinical use case, we find that the majority of those approved devices are for radiology. All of those other clinical uses for cardiology, neurology, et cetera, really make up a small fraction of those approved devices that has remained relatively stable over the years. The unfortunate reality is that many of our machine learning models that have been developed over the years have not made it into the clinic, and models that are deployed often typically perform worse in the real world, right, compared to their preclinical performance. One striking historical example of this is the use of CAD, or computer-aided diagnosis algorithms. CAD systems were deployed in around 74% of screening mammography programs by 2010 before they were found to have both lower sensitivity and specificity compared to radiologists. This really raises this question, right, of why do we see this deployment gap? What makes ML for healthcare so challenging? And, to answer this, we think about how these current models are typically developed. We typically train our models on a large retrospective data set for a narrowly defined task. And then, of course, the problem is that when the models are deployed, the patients in that data set often don't look like that training data set. As you all know, in the real world populations, clinical presentations are extremely heterogeneous. Changing technology and behavior can lead to data set shift. For instance, the adoption of a new order set or changes in ICD coding patterns can lead to significant deterioration in model performance. We might be able to simply address these issues by collecting more training data, but of course that data is siloed across institutions. Simply learning features from the data alone can be challenging because healthcare data is noisy and often contains artifacts due to the business of medicine. And even if we did have access to all of that substantial, training data, annotating that data for more traditional machine learning approaches can be costly and time intensive due to the medical expertise required. So I kind of argue that to safely deploy machine learning models that can handle these kind of challenges, we really need approaches that can generalize across the diverse settings that we are seeing in the clinic, and approaches that can adapt to these settings without requiring extensive amounts of expensive annotated data. So this brings us really to a core question of our lab's work, which is how can we leverage medical domain knowledge to produce more generalizable and scalable machine learning models for healthcare? Integrating medical domain knowledge more explicitly into machine learning models has a number of benefits, of course. Allows for better generalizability, requires less annotated data. We can produce models that are less likely to rely on spurious features in the training data, and it can help us produce more explainable models as well. There are, of course, many different ways that we can either implicitly or explicitly incorporate domain knowledge into our machine learning models, whether that's the choice of model architecture or the loss function, through self-supervised learning, pre-training objectives, through data simulation or augmentation, or by explicitly leveraging knowledge that's captured in text data or graphs. So today I'm going to talk about some of our work to leverage explicit domain knowledge found in biomedical knowledge graphs to create simulated patients to augment training in settings with limited annotated data, and then also to encode domain knowledge through clinical pre-training of models as well. So I'll focus on a few key motivating questions here. First of all, how do we leverage external knowledge in biomedical knowledge graphs to generalize across populations? How can we, again, develop medical foundation models to scale model development? And then finally, when we train a model on non-clinical data, let's say, of course, all of the text in the internet, what kind of biases, what kind of associations are our models actually learning in this instance? So I'll start by talking about our work to leverage biomedical knowledge graphs to develop generalizable models here. And this work was actually motivated by this clinical challenge of diagnosing patients with rare genetic diseases. Rare diseases affect 1 in 20 people worldwide, yet each disease affects no more than 50 per 100,000 individuals. Some ultra rare diseases only will affect a single individual. So this is very much, a few-shot learning challenge. 80% of rare diseases have a genetic origin, and genome sequencing tools have been developed to try to pinpoint the genetic mutation that explains the patient's particular condition. However, diagnosing these patients is really challenging due to the heterogeneity of the patient's clinical presentations, as well as the large number of candidate genes that clinicians have to sort through to effectively identify a patient's molecular diagnosis. So as a result of this, many patients suffering from these diseases, typically undiagnosed, it can take 4 to 5 years on average for a patient to receive a diagnosis. So our key question for this work is really whether we can then leverage these deep learning methods to accelerate the diagnosis for these rare disease patients. We've seen deep learning methods achieve tremendous promise in other areas, detecting diabetic retinopathy, classifying skin cancer lesions, diagnosing pediatric diseases from patient electronic health records. It's kind of a natural question. Okay, can we apply similar approaches to rare disease diagnosis? However, of course, the challenge is that these advances, at least historically, have depended on the existence of these really large annotated data sets with thousands of examples per condition for training these kind of deep learning models. And machine-assisted diagnosis of these rare diseases encounters challenges that are distinct from those other use cases. Given the lack of large annotated data sets, these approaches need to be able to learn from a limited amount of training data. This is particularly important because due to the low prevalence of these diseases, even if we were able to manually curate all of the data in the world, it's unlikely to produce data sets sufficiently large to use more traditional deep learning approaches. And then furthermore, these approaches really need to be able to extrapolate beyond their training data to either atypical disease presentations or even potentially never before seen genetic conditions as well. So let me give you a better idea of this challenge using patients from the Undiagnosed Diseases Network. The Undiagnosed Diseases Network, or UDN, is a multi-site program across the US where the goal is to diagnose patients with these rare diseases. Of 465 diagnosed patients in the UDN, there's around 378 unique causal genes represented, 299 unique diseases represented. Most genes, phenotypes, and diseases are only seen in a single patient in the entire cohort here. Even within the same disease, these patients will have considerable phenotypic heterogeneity. They share only around 67% phenotypes on average, and only 28% of patient phenotypes are actually known to be associated with the patient's causal gene. What this means, again, is that these patients have really atypical presentations of diseases or potentially completely novel genetic conditions. So to address these challenges, our kind of key insight here was to develop a model that can both learn from patient cohort data as well as incorporate external knowledge graphs of known gene phenotype and disease associations. And in particular, we created what we call Shepherd, a few-shot predictor for hard-to-diagnose rare diseases. So Shepherd is a deep learning approach that incorporates external knowledge to, again, be able to learn from that limited data and generalize to new, never-before-seen genetic conditions. So concretely, Shepherd will take in as input a patient's set of phenotypes or symptoms. These are typically encoded as human phenotype ontology terms. And it will also take in an optional list of candidate genes and then leverage that external rare disease knowledge graph and external patient cohorts to perform multifaceted rare disease diagnosis. So it can perform causal gene discovery, retrieving patients like me with the same causal gene or disease, and provide interpretable characterizations of novel disease presentations as well. So more concretely, for causal gene discovery, we're asking the question, given a patient set of phenotypes and a list of candidate genes, which genes are most likely to explain the patient's presenting symptoms? So this is a gene ranking problem. For patients like me, we're asking, given a patient set of phenotypes and an external cohort of rare disease patients, can we identify other patients with similar genetic conditions? And then finally, for novel disease characterization, we're asking, given a patient set of phenotypes, a set of known diseases, can we characterize the clinical presentation of this new patient based on our current knowledge of rare diseases? On top here, what you're seeing is a diagram of the current UDN diagnostic process, and our model can integrate throughout multiple different steps throughout this process. After phenotyping alone, where the patient's clinical presentation is captured by these standardized phenotype terms. After sequencing analysis produces an initial list of candidate genes that are generated using these variant level filtering techniques. These techniques will filter a patient's genes based on, for instance, the frequency of a variant in a population. So if a variant's really frequent, it's probably less likely to cause really rare disease. And then finally, the model can work after there's this iterative back and forth case review process with clinicians that has filtered down this list to an expert curated list of candidate genes that clinicians still can't try to figure out which gene is actually the causal gene. So there are three key features of Shepherd that enable it to work. First of all, we actually train Shepherd on simulated but realistic rare disease patients. So training on these simulated patients is actually very important because those 465 UDN patients in our data set just are not enough patients to train a deep learning model. So we use the simulated patients for training, and then the UDN cohort serves as a completely external cohort for evaluation. Secondly, we model patients as subgraphs in the context of a larger rare disease knowledge graph. So each patient's set of phenotypes becomes a subgraph, and then the candidate genes or diseases are individual nodes in that knowledge graph. And then we use a graph neural network-based approach to generate representations of those patients that are then informed by all of the existing knowledge in the knowledge graph. This step is important because it gives us that opportunity to infuse external knowledge into our model. And then finally, we leverage label-efficient approaches to train the model. Shepherd learns to capture the similarity between patients' genes and diseases by training the model to generate representations of each patient such that the patient is nearby the patient's causal gene and disease and other patients with the same gene and disease, and then far away from irrelevant genes and diseases in this learned embedding space. So I'm going to go into a little bit more detail about each of these features. As I mentioned, Shepherd's trained on this simulated patient cohort, around 42,000 patients, representing over 2,100 diseases found in OrphaNet, which is this rare disease database. To encourage the model to generalize to new diseases, we perform disease split training, where we assign patients to our train and our validation sets by disease. We developed a separate method for simulating these realistic rare disease patients. I'm going to skip the details of exactly how the simulation process works for now. I'm happy to answer questions about it. The key thing to know really is that this simulation process produces patients with meaningful and challenging candidate genes that the model has to learn to differentiate between. And by training on these simulated patients, we're encouraging the model to learn to ignore phenotypic noise and to be able to handle missing phenotypes in the patients as well. And also importantly, we're using this like domain knowledge guided process for simulation rather than an approach like GANs, because there's just so limited amount of data that we need to use that real patient data for evaluation of the models. And then we evaluated Shepherd on those patients from the UDN that I mentioned earlier. These patients have some of the most difficult to diagnose conditions. They've often gone years struggling to find a diagnosis, had previously received genetic sequencing from their original clinician who couldn't still, with that original sequence, figure out what disease they actually had. So each patient in this cohort will have, again, a set of phenotypes, candidate gene lists, a causal gene, and then coded disease if the patient is actually diagnosed with a known disease. Patients will have around 23 phenotypes on average, and then the two candidate gene lists have around 13 and 244 genes on average that the clinician has to sort through to identify which gene is the actual causal gene. We leverage this knowledge graph to incorporate external knowledge into Shepherd. The knowledge graph contains edges from genes to phenotypes and diseases. And there are also additional gene-gene edges as well that connect the gene nodes to pathway nodes, functional similarity nodes, and other interacting genes. The knowledge graph contains around 100,000 nodes, 2 million edges, and multiple different scales of relationships as well. So here's on the right is just some sources of information that are found in this knowledge graph. And the important thing I think to note here really is that we're including information not just about existing gene phenotype associations, but also these gene-gene associations as well, which we find later that this is actually important to be able to generalize to diagnose patients with novel genetic conditions where that existing gene phenotype relationship wasn't already known. Yes, please.
I'm curious, rare diseases usually, are they enriched for protein coding or is this non-coding, transcriptional problems? And how do you capture that within this kind of relationship?
It's a great question. So right now we are modeling basically the gene to phenotype level rather than individual like potential variant of whether it's coding or not coding. The input at this point is a VCF file that goes through variant level filtering approaches based on that, and then we map from the variant to the individual gene level. I do think there's a immense opportunity here to expand this graph that we use to include individual variant level or other genetic modifications in the graph as well. In the inclusion criteria for the UDN, there's often some suspicion that these patients have a Mendelian disease for them to be included.
Okay, but it could be just any kind of Mendelian trait, heritable, and then copy numbers, non-coding variants, structural variants, doesn't matter, right? Okay.
Yep.
Thank you.
Yeah, good question. Okay, so I mentioned that Shepherd is deep learning approach, leverages graph neural networks to embed the patient. Before I go into the details really about how Shepherd works, just quick recap about how graph neural networks work. So GNNs generate node embeddings for each node in the graph based on the node's local neighborhood in that graph. So many GNN models are framed as what's called a message passing architecture. Initially, the node embeddings are initialized as node features. And then for each layer and node V, messages are sent from the nodes in the neighborhood of V. Those messages are aggregated and then used to update V's representation. So what this means in practice is that the final representation of any node V in the graph after K layers of the graph neural network depends on nodes that are most K hops away in the graph. So each node's representation is informed by all of the neighboring nodes in that graph. Okay, so with that in mind, how does Shepherd work? So Shepherd's trained in a two-step process. First, the model is pre-trained to embed all of that biomedical knowledge in the knowledge graph. So during the pre-training process, you randomly sample nodes from the graph in each batch. You pass these nodes through multiple layers of a graph neural network to generate embeddings for each node. And then the pre-training is simply a self-supervised pre-training approach to predict whether an edge exists in the knowledge graph or not. And then after we've done this pre-training of the model, we then apply that model to our actual multifaceted rare disease diagnosis task. So at this point, the input is the patient's set of phenotypes, and then depending on the task, set of candidate genes or diseases or other patients. We overlay that patient information on the knowledge graph, constructing patient subgraphs from the patient phenotypes. We then leverage that pre-trained graph neural network model to embed each candidate as well as that patient phenotype subgraph. So Shepherd will generate a single patient phenotype embedding from all of the phenotypes in the patient by performing an attention-weighted average of those phenotype representations. So at this point, we have an embedding for the patient that represents the aggregated patient phenotypes, an embedding for each of the candidates, and then we again train this model via a loss function that encourages those patient embeddings to be close to the embeddings of their causal gene or disease or other patients with that same gene or disease. This is just the kind of high-level idea of the training process. The core idea is we're effectively learning the similarity metric between the patient phenotypes and either the candidate gene or disease or patient that's reflected in that learned embedding space, so that at inference time, we can then use that similarity to be able to rank candidate genes or diseases or patients. So I'm going to now switch to talk about our findings. In the interest of time today, I'm just going to discuss our first two applications here, starting with the ability to perform causal gene discovery. So here, given a patient set of phenotypes and a list of candidate genes, again, which genes are most likely to explain patient symptoms? So we evaluated the model on those patients from the UDN that I mentioned earlier. On the x-axis here, what you're seeing is average recall at K. So that's the number of causal genes retrieved in the top K ranked genes on average across all patients in the UDN cohort. So we find that Shepherd is able to rank that causal gene first, 43% of these patients, achieving a recall of 0.71 when K is 3, 0.86 when K is 5 on average. And then we compared Shepherd to several representative domain-specific network science, machine learning-based approaches, found the model can perform significantly better than those baselines, including outperforming other machine learning approaches by over 250%. Effectively, what this means is clinicians need to review substantially fewer genes compared to those approaches. And interestingly, you can see actually both language models we evaluated performed substantially worse, even worse than most domain-specific models from the field as well. And these findings actually about the poor performance of language models actually aligns with existing literature, where other papers have shown that current language models, including OpenAI's O1 model, fail to outperform domain-specific models for this rare disease diagnostic task as well. And, it's actually not that surprising if you think about current foundation models do struggle to effectively encode structured knowledge, such as the information captured in databases or knowledge graphs. There was a different paper here, this is a little bit older, but found that many language models can't recall structured genomic knowledge, such as gene names and gene disease associations. And as one a bit aside here, we found that when there are different ways of referring to a gene name. You can refer to it by a gene symbol or an ensemble ID. Ensemble IDs are basically strings of numbers. And the model performs much, much worse if you represent the genes as these strings of numbers compared to their gene symbols. If you think about the frequency of how often those names are mentioned in the pre-training data, as well as just the ability of language models to encode numbers as well. Anyway, as an aside, so we evaluated Shepherd's performance on UDN patients across clinical site, evaluation year, primary presenting symptoms, and found that it can generalize across each of these settings. There's no real statistically significant difference in performance across site, year, or symptom presentation. And we also wanted to look at the performance on those really most difficult to diagnose cases of patients who actually potentially had a novel disease or novel disease gene. And again, here found this kind of consistent narrative where the model performed the highest performing baseline approach on these more difficult to diagnose cases as well. I'm going to switch gears now and talk about the ability to retrieve similar patients given a patient's phenotypes. So we also found that the model can learn patient representations that capture these patient similarity. So what you're seeing here is a visualization of all of the patient embeddings in a 2D UMAP space. Each patient point is colored according to the disease category of the patient's disease. The circles here correspond to those simulated patients. We overlay on top these. So triangles correspond to the UDN patients. The inverted triangles are another set of rare disease patients from my gene 2. And the model learns to embed patients with similar diseases near each other. You can see this maybe a little bit more easily when we plot each disease category by itself. So here are all the patients with neurological diseases. UDN patients are near the simulated patients with similar diseases. And this trend holds true across many different disease categories as well. Now, importantly, there is also overlap between these disease categories, and this overlap actually represents the fact that these patient disorders often involve multiple different organ systems. So consider as an example here the overlap between these patients with hematologic and hepatic diseases. On the right are 2 patients found in those overlapping clusters. They both have symptoms from each category. And you can see this kind of visually in the illustration on the right, where the red hematologic symptoms in the patient with a hepatic disease and vice versa there. We can also quantify this similarity in a heat map. So here we're comparing the distances between the embeddings of pairs of patients with either the same or distinct disease categories. As we'd hope, the distances between patients of the same category are much smaller than distances between patients of different categories. This is true across all disease categories. And you can see this in the heat map diagonally, where the diagonal is much darker than the off-diagonal entries. We can then leverage these learned notions of patient similarity to actually identify patients like me. So there's an example patient on the top left there. And for this patient, we rank all patients in our cohort over 40,000 in total, including the simulated patients, to try to find those most similar patients. And the top 5 most similar patients are shown on the left there. The patient with the same disease as that query patient is ranked second. Now, interestingly, we see that those most similar patients identified by Shepard do not actually have the most phenotype terms in common with the query patient. So the patient with the same causal gene only has 2 phenotypes, or 10% in common, whereas the 366th ranked patient has 5 phenotype terms in common. This is actually a good thing because it's indicating that the model is learning an embedding space that captures semantic phenotype similarity beyond just direct HPO term overlap. And then, of course, we can also quantitatively evaluate the ability to identify patients like me. Here, we're comparing the real external UDN cohort to all real external MyGene2 patient cohort. And we can compare the performance to a baseline. And similar to the causal gene discovery task, we're using average recall at K. So the number of similar patients retrieved in the top K ranked patients on average across all the UDN patients. And again, we find Shepard can rank patients like me higher than this baseline approach. So just to summarize this portion of our work, Shepard's able to perform this multifaceted diagnosis and generalizing to these never before seen phenotype genes and diseases. The key real methods, I think, components here that enable this to work are infusing this external knowledge via deep learning on the knowledge graph, training on this large disease split cohort of the simulated patients, and then leveraging this label efficient training to warrant this meaningful embedding space. And the additional benefit of training on this simulated data is that we actually were able to release this model publicly to the community without any privacy concerns as well. I'll also just say that I think this approach of representing patients as subgraphs in the context of a broader knowledge graph, is potentially generalizable to other clinical scenarios as well. For instance, constructing patient subgraphs from a knowledge graph derived from ICD codes or other structured codes found in EHR data or claims data as well. So before I move on, does anyone have any questions so far on this part?
So Emily, I have a question. This is fascinating, especially I'm curious for this simulation part. Do you think this type of approach can work for common disease as well?
It's a great question. I think let me go to what was unique, I think we took advantage of for our simulated patients. So what worked here for the simulation process is that we had these external knowledge sources of information that we could leverage to ground the simulation process. So most of this was based on this database called Orphanet, which has, for instance, relationships between genes and given diseases, and as well as the likelihood of a phenotype appearing in a given disorder as well. So we can, for instance, initialize the phenotypes for a given patient according to that, with some probability P that they're actually found in a given patient. And then we go through these processes, you can see on the left here, of mimicking the diagnostic process where not all phenotypes are found in a given patient, where there might be phenotypic noise, which we added from including background phenotypes from a medical claims database. And then on the gene side, it was again thinking about what are potentially challenging distractor genes that we want the model to be able to learn to differentiate between. So whether that is a gene with a similar tissue expression as the true disease, or a gene that causes overlapping phenotypes with the patient, but are for some reason or another not causal relative to the true gene that is explaining these patient symptoms. So I think that kind of approach is certainly generalizable. It's just thinking about what is the appropriate knowledge source that you use in that scenario.
Yeah, thanks.
Aaron?
Yeah, thanks. So how does this compare? Have you looked at how this compares or thought about using it as an input? Things like, the EVO or these other LLM learned models where they predict the pathogenesis of unknown variants. Do you find the same results?
It's a great question. We haven't tested that yet, but that is certainly on my list of to do. I think we're taking a phenotype-based approach to prioritization, and our approach right now is effectively do variant-based filtering and then do this phenotype-based approach on top of that. But I think there's certainly an opportunity to more directly infuse both of those kind of approaches together. And I think this graph formulation, you can imagine either initializing for each node in the graph some features associated with that gene, which might be derived from external information as well, or more directly, fusing that later in the model. It's a great point.
Yeah. So quick second question, kind of related to your embedding space. What do you think really makes your space work better with these genes? Is it the network? Because you mentioned that genes don't tokenize well, right? But you're finding things that are putting genes and patients in the same space here.
Yeah, exactly. I think it is the selection of the knowledge graph together of how we are encoding genes. A gene now is a single node where you're not having to deal with the tokenization that you would deal with a language model. I also suspect that at least a good portion of these resources that we're including in the knowledge graph might not actually make its way into the pre-training for these language models. They're often, structured as databases that are probably filtered out through the pre-training filtering process. So that is also one probably contributor as well.
So then how much do you think you're losing by restricting to these known, well-characterized genes, right? Someone has a mutation in some weird antisense gene that's never been characterized, right?
Yeah. No, it's a good point. We did consider adding in PubMed as well, just derived from PubMed as an additional feature here. Our initial experiments found that was too noisy because we were effectively making saturating the graph. I think that has made more of a limitation perhaps of current graph approaches, or the lack of including weights on the edges. So I think that's still a promising opportunity. We're also considering right now exploring the benefit of using language models and graphs combined together, where you kind of get the best of both worlds.
Thank you.
Yeah, great questions. All right, I will then move on unless there are any other questions. So we're going to switch gears a little bit. At this point, I've been talking about how we've been leveraging explicit information in these knowledge graphs to incorporate domain knowledge into our models. I'm now going to switch gears and talk about how we can implicitly encode domain knowledge through clinical pre-training of these models. And, you all know at this point, we've seen huge advances of language models over the last few years that have really dramatically changed the way we develop NLP models. Whereas before we had to have a single model for each task, now we can develop a foundation model, pre-train it via some self-supervised learning, apply it to many different downstream tasks. The challenge is that these foundation models have demonstrated really incredible performance across many settings, Most of these models are trained on general domain data. This, of course, is a challenge for using language models for clinical applications. Such general domain data is not necessarily representative of clinical notes, which often contain medical terminology and abbreviations, have incomplete sentences. The text is often semi-structured, often written using templates. And interpreting that information in the clinical notes, such as the meaning of lab values, requires domain knowledge that's not typically present in the internet data that you'd see for training like a GPT type model. Furthermore, if you think about the patient presentations in the EHR data, those don't actually necessarily look like the classic presentations you might find in medical textbooks or the atypical presentations you might find in PubMed case studies, which are going to be found in those general domain language model pre-training. So, to address these challenges, a common paradigm in the field for the last 7 years plus has been to perform continued in-domain pre-training on clinical data. Back in 2019, we created Clinical BERT by further pre-training a BERT-based model on clinical notes from Mimic, which is an ICU from Beth Israel Deaconess Hospital in Boston. This work has showed that in-domain pre-training on this clinical data can lead to improved performance on clinical NLP tasks compared to both general domain and biomedical models. However, in light of the recent advances in language modeling over the last few years, the release of ChatGPT, et cetera, I think this begs the question of, can we just use larger general domain models instead? Do we still need specialized clinical models that are trained on EHR data? So to answer this question, we considered the perspective of a resource-constrained hospital system that's attempting to automate a clinical task involving EHR notes using as few resources as possible. For instance, suppose a hospital wants to implement semantic search of clinical notes, and they would like to use a language model to allow the hospital to automatically extract answers to questions about a patient's medical history. So to tackle this kind of question, hospitals typically have one of 4 different options. They can either train a model from scratch, to, create their own specialized clinical model via pre-training on clinical data. You can do domain adaptive training, where you take a pre-trained model on general domain model text. You do continued in-domain pre-training. You can fine-tune a general domain model, or you can do in-context learning, of a general domain model via prompting-based approaches. So, given these kind of options and this kind of key question, this kind of led us to investigate, again, what is the utility of clinical models in this new world? So our prior work with Clinical BERT had already demonstrated that these specialized clinical models can outperform general domain models of the same size. However, can these specialized clinical models outperform larger general domain models? Does training on clinical data produce more cost-effective models? And then finally, do these smaller fine-tuned clinical models outperform more recent prompting approaches for larger language models? So let's start with this first question of whether these clinical models can outperform general domain models. And to investigate this, we would fix the model architecture, compare general and clinical language models of varying sizes. So compared 3 general domain models. These are all T5 models: T5 base, T5 large, T5 XL, which have increasing number of parameters respectively. We also compared them to a specialized clinical model that's further pre-trained, starting from the general domain model T5 base. And then we also compared to 2 additional specialized clinical models of different sizes that were trained from scratch exclusively on clinical data. And we evaluated these models on 3 different clinical tasks. The first is a natural language inference task, asks whether a hypothesis can be inferred from a premise. Hypothesis can either entail, contradict, or be neutral to the premise. The second is a question answering task over radiology reports, where the goal is to find the text in the report that answers the question. And then the third task is a multi-label classification task of discharge summary sentences, where here the goal is to identify whether each sentence in the summary contains different types of follow-up information. So we compared all models across these 3 tasks, and as kind of expected from prior work, the clinical models outperformed general domain models of comparable size. So clinical T5 base outperforms T5 base. Similarly, clinical T5 large outperforms T5 large. We also found that the clinical models can outperform 3.5 times larger general domain models. So here, the 220 million parameter clinical T5 base outperform the 770 million parameter T5 large. And then you see the same trend again for clinical T5 large and the general domain T5 extra large. Now, there is a point at which having a larger model is more beneficial, though, than clinical pre-training. So the T5XL model does outperform the much smaller clinical T5 base model. So we've shown, these specialized clinical models can outperform larger general domain models, at least to an extent. Now, what about whether these models are more cost effective? Again, thinking about this context of a hospital that doesn't have a lot of compute resources to use these models, either training or inference. To answer this question, we have to define how we want to measure the cost of a model. So we can define cost of training in terms of the number of floating point operations or flops needed for training. So flops are a function of model size, so the number of model parameters, as well as the amount of training data that the model is trained on. So here we're plotting performance as a function of the number of flops used to train the model. In orange are these clinical models, in blue are the non-clinical models. Shown here are all of those models with the same architecture that I discussed earlier. We also compare against several additional clinical and general domain models that have different architectures as well. And we find that training on the in-domain tokens is more valuable. So clinical models require fewer flops to achieve the same performance. Furthermore, for a given amount of flops used to train the model, clinical models achieve higher performance as well. And these results hold true across all three of those data sets that I showed you. Now, I'm going to skip the details of this in the interest of time, but we also did this analysis to look at, at what point is it computationally less expensive to pre-train a smaller model from scratch versus use a larger domain agnostic model. Turns out if you do these calculations and make these assumptions, it'd take about 40 billion tokens of inference to recover the cost of pre-training from scratch on clinical data. But for reference, using the University of Florida Health as a baseline, it records around 15 billion tokens per year. So it'd take 2.5 years to recover the cost of a specialized clinical model that runs over each node a single time. But as you would imagine, we'd be using these models for multiple different tasks over multiple different years to make up those costs. And then finally, we investigated whether these smaller fine-tuned models can outperform prompting approaches of larger language models. So here we're measuring on the x-axis the performance on each task as a function of the number of training examples used to fine-tune that model. So the solid lines here represent the fine-tuned models. The dashed horizontal lines represent the performance of the prompting approaches. We found that these smaller fine-tuned models outperform the future prompting approaches of these larger language models, even actually when they're only trained on a handful of the training examples. The fine-tuned models actually perform much better on this last multi-label classification task here. This was likely because the label space of this task is very different than the types of tasks that the two much larger general domain models were trained on. Now, this work was conducted before all of the more recent GPT-4 models were released, but there have been others that have shown and extending our work to show similar findings for more recent models as well. So, I think recent language models have shown really impressive performance. There are still some reasons why you might want to leverage a smaller clinical language model, particularly on classification tasks or other spaces where defining that label space can be really challenging. I think there's a lot of exciting work here to combine the strengths of these larger general domain models, though, to more specialized clinical models. I'm going to skip over these in the interest of time, just to say that we've done some work in using language models for phenotyping and subtyping patients, as well as summarizing patient medical records and generating responses to patient portal messages as well. So I think to recap at this point, I think we need to consider when we're evaluating language models, not just the performance of these models, but their computational efficiency as well, and how under-resourced and community hospitals may be able to benefit from these new methods. I think we'll see API costs certainly decrease over time, but hospitals process an enormous amount of data. And when they're considering the cost of deploying these models, particularly at the scale of millions of patient messages that they see, I think we'll see an increasing push towards more cost-effective clinical models that are more reliable and tailored to an application of interest. All right, so I'm now going to pivot one last time. So at this point, we've talked about how we can implicitly encode domain knowledge through pre-training. However, this pre-training process can also lead models to learn unwanted associations that might be found in the training data. So I'll talk about our work to uncover the biases that these models are actually learning. As you likely know, language models are already being used in the clinic at this point. The EHR vendor Epic is integrating GPT-4 into administrative workflows. Startups are deploying tools for ambient documentation. Most of the focus has been on administrative tasks, but many clinicians are envisioning using these models for clinical decision support. There was a recent survey of UK physicians that found that 1 in 5 respondents reported using generative AI tools in their practice. And then of these, 28% said they were using them to suggest a differential diagnosis, 25% were using them to suggest treatment options. Now, despite this excitement around leveraging language models, we still actually really don't know how well these models perform on diverse populations. This is concerning because a ton of research has shown that these models can encode societal biases that are present in their training data. For example, on the right, when a model was given the prompt, patient became belligerent and violent, sent to blank, the model would fill in hospital for Caucasian patients, prison for African American patients. Now, some of these biases, once they're identified, can be addressed through additional approaches like training, reinforcement learning with human feedback, but this itself is a human process which can be imperfect and introduce its own biases as well. In fact, biases can appear throughout the model training process, from the availability and selection of the pre-training data to filtering of that pre-training data to data mixing approaches for pre-training to the choice of tokenization that you use for the model, to the selection of the instruction tuning data and selection of annotators, as well as during preference tuning as well. So to address this gap, we evaluated whether GPT-4 perpetuates racial and gender biases in clinical applications, focusing on 4 different clinical use cases: medical education, diagnostic reasoning, clinical plan generation, and then subjective patient assessment. So today I'll just discuss these first 2 applications. Language models really have this potential, I think, to advance medical education by generating clinical vignettes for case-based learning. However, the challenge is that we need to ensure that these cases that the model generates actually accurately portray disease prevalence and presentations to be able to train physicians to practice equitable medicine. So we asked whether the language model can capture the demographic diversity of medical conditions while generating these clinical vignettes. What we do is prompt the model to create a patient presentation for a supplied diagnosis, do this for 10 prompts, repeating 100 times per prompt. And then we can examine the demographic distribution of the cases generated by the model to the known demographic prevalence in the US for each condition. So what we found is that the model really fails to model the demographic diversity of these medical conditions. It would often exaggerate stereotypical associations between demographics and disease. So for example, when asked to describe a case of sarcoidosis, the model would generate a vignette about a Black patient 97% of the time, female patient 84% of the time, and a Black female patient 81% of the time. Now, sarcoidosis is more prevalent in Black females, but this is still an exaggeration of those prevalence differences. We also observed that Hispanic and Asian populations were generally underrepresented, except again in these specific stereotype conditions such as hepatitis B, where they were overrepresented compared with US-based prevalence estimates. We tried 2 approaches to de-bias the model through prompting. Our first strategy was asking the model explicitly to be wary of stereotypes or bias. For the second strategy, we asked the model to consider the demographic prevalence of the disease when generating these vignettes. Neither of these approaches really worked. Instead, they would just increase the representation of minority groups across the board without really regard to the prior prevalence of any particular condition. We also evaluated the diagnostic performance of the model by race, ethnicity, and gender. So here we were leveraging cases from any JM Healer, which is a medical education tool that presents expert-generated cases and allows medical trainees to compare their differential diagnosis to an expected differential. And we, in particular, selected cases that should have a similar differential by race and gender for this analysis. So for example, we'd exclude cases of lower abdominal pain, which should have a different differential for female and male patients. So substitute the race and gender for each case, prompt the model to generate a differential diagnosis, including the top 10 most likely diagnoses for a particular case. And here again, we found that really changing these demographics affected the model's ability to provide the correct diagnosis in 37% of the cases. So to give you an example, in a case of pharyngitis in a sexually active teenager, the model got the diagnosis, which is mono, correct for 100% of white patients, but only 64 to 84% of minority patients, where it opted to rank the STD gonococcal pharyngitis first instead. You can see that on the right, where the model is more likely to rank HIV, syphilis, and gonococcal pharyngitis higher on the differential for minority patients compared to white patients. So, I think overall, there's concerning evidence that these models not only propagate harmful societal biases, but these might lead to disparate diagnosis and treatment recommendations. I think we often talk about a language model being deployed with a clinician in the loop, but it's not necessarily clear to me that a provider would be able to identify these biases in these language models when examining only individual patient cases at a time. So I think we really need these targeted fairness evaluation for each intended use of language models, as well as these kind of post-deployment bias monitoring and mitigation strategies to ensure these models are deployed safely. I'm just going to briefly skim through the rest of these in case there's time for a few more questions, but there's this broader landscape of kind of language model bias evaluations in healthcare. What we did with our work was counterfactual evaluations across different groups. There's also an area of performing red teaming or adversarial evaluations as well. We examined the counterfactual evaluation analysis papers that had been published since ours, and we found that most works evaluate the use of language models for tasks that have structured outputs, even though many uses of language models are generative in nature. And most works evaluate performance across explicit demographic groups, mainly race and gender. There's only a handful that examined biases in unstructured outputs. Really only one paper that looked at biases as a function of implicit or inferred demographic or social groups from a text-based input. And then finally, notably, almost all of these analyses use either human or language model generated data sets specifically designed to probe for bias rather than using real-world data. So I think really what we're missing here is comprehensive bias audits for real-world clinical applications. So for example, there's a currently deployed tool in Epic right now. I think it's deployed at around 300, in pilot phase at least, 300 different hospitals across the US, where these models are used to generate draft responses to patient messages. We need to do these kind of bias audits for these kind of real-world applications. For instance, where we're looking at, what are the relevant social groups that might be harmed, and then what harms are possible. Looking beyond just the accuracy of a given message, but also, is there a difference in tone? Is there a difference in length across these different messages as well? So I will leave you with just a few open questions that I think are exciting future directions in this work to think about how we're designing trustworthy, clinically useful ML applications that can actually bridge that deployment gap. I won't go into too much of this here and open up if anyone has any questions.
It's fascinating. So for the audience, if you have a question, you can ask Emily directly or put it in the chat. I'll just start by asking one question on the last part. You talk about this bias of LM in medical applications. What about some concrete mitigation strategy? And we have used, not for the LM usage, like the traditional classifier type of setting, using data augmentation, right? It's actually tied to some of the simulation work you talked about at the first part to make the training data more diverse, right? Then you train on that more diverse training set, maybe, or it can mitigate, like reduce the bias for the classification task. For the LM settings, are there some strategy that you want to share with us?
It's a great question. I honestly haven't seen this at all explored in the medical domain. What people are typically doing as kind of a backstop is to effectively have output guardrails on the outputs of language models that will then say, effectively, a language model is a judge to say, is this output potentially biased? And then you have some sort of trigger that will say, oh, I either don't respond or revise in that context. There is some other work in using what's like basically a much smaller language model that is specifically fine-tuned on some like debiased data set. And then what you can do at inference time is take the, like the probabilities for each token, and you take the delta in those probabilities between the biased model and the anti-biased model. And then you add those probabilities to the much larger model to effectively try to do test time debiasing of these models. But I think it's very much an underexplored area. Most of the work has found that any work that tries to debias at the embedding space often doesn't actually correlate with debiasing of the downstream task. So my suspicion is that some of this debiasing will have to be task specific.
Interesting. Aaron, you want to clarify your questions here about the property of the ReLU function?
Oh, if anybody else has questions, let them go first. But in text, yeah. But the general category of imbalance in the training data was certainly bias, right? Versus what you want to output in a more proportional to your use case. Like, is there any general theory here about why is this a categorical thing that a large language model just will fail on multiple categories, or is this something that's, you think, specific to the way that the text is coming through?
How does this, can you relate back to the ReLU function, what you mean by that?
I mean, so like a lot of the activations in these layers, right, you're flattening a lot of stuff, right? And sure. So I'm wondering if, like, when we have like just if 10% of the population is one ethnicity, but a lot of the training data is overrepresented on the other, is this something that's specific to those kinds of ratios, like where mathematically the large language is going to have a struggle to output correctly because we flattened things some way, so it goes instead of being 10, it goes down to like 1, right? It's exacerbating the biases.
That's interesting. I hadn't thought about it in the context of ReLU before. I mean, I do think our objective function certainly can encourage, overall performance, which might occur at the expense of particular demographic groups. One area, actually going back to the debiasing question, a common approach, really, regardless of whether it's a language model or not, is adding an additional constraint to your objective function to try to, for instance, this can happen at the embedding level where you encourage the representations of similar groups to be similar, or it can happen at the output probability level where you want some probability distribution to be similar across different groups. Yeah, that's a good question. I'm not sure about the extent specifically. Interesting idea. I'll also mention one other idea for debiasing. Sometimes people will, during the decoding process, like the brute force approach of this is to basically you have some like words that are forbidden that you can, not allow decoding of that. There's also some work that looks at steering that decoding process based on external like toxicity classifiers. So you can reweight those probabilities at decoding based on these external models as well. And then finally, I guess the data selection side, there's also some work that looks at, you basically train a much smaller, shallow model on a data set, and you assume that if that really shallow model can do well on a particular data, that it's probably learning potentially spurious correlations. And then you use that to actually filter out those examples for fine-tuning the model.
And I like that idea. Cool.
Yeah.
Cool. Thanks, Aaron, for the question. I know we're kind of running out of time. I want to close out with this question I always ask the speakers. I mean, in your case, Emily, you're one of the few computer scientists actually work on ML models for clinical application that actually deployed into clinics. And so for a lot of PhD students in computer science today are eager to work in AI for healthcare and medicines. What is some of the non-obvious skill or perspective that you you wish more students would gain during their PhD study. And that now you're looking backwards and okay, that's a very important skill that you should have if you want to work on AI for healthcare.
That is a great question. I will say I had the benefit of doing this quite unusual PhD program where we did half of the first 2 years of med school classes and then did 2 6-week rotations in the hospital, learning about that kind of clinical workflows, which for me has been very valuable in thinking about what are really useful clinical problems to work on. I think the higher level, I guess, advice and what I learned through that process is having a really thorough understanding of the data generating process for any data that you're using. The kind of missteps that I see often happen when you make assumptions about when a given data might be available and how that data, like what are the assumptions in terms of how that data will generalize. To give you a very concrete example of this, many notes in the EHR are written by note templates. And a lot of that data that's found in a note is automatically populated from structured portions of the record. So I've seen things like people try to automatically generate those structured portions of the EHR data, which is just already being auto-populated. And so, getting enough in the weeds on the clinical side helps you ask and better develop your methods to adapt to those data generating processes.
Yeah, that's definitely a very important insight. I find surprisingly a lot of the CS PhD students are not that eager to understand the data generation process, right? They were leaning towards, if someone create a benchmark,
recording stopped,
then we can start using it, right? Beat the benchmark and show my own method is better than some other method without thinking too much about how the data is actually created. Are there some issues, and what does those data set really means? But that's a very important comment. Okay, with that, thank you, Emily, for the fascinating talk, and I think we all learned quite a bit on this.